This is Savannah Smith, and I'm going to be presenting my oral case presentation on Mycoplasma pneumonia or atypical pneumonia. The patient that we will be looking at today is a 41-year-old Caucasian male who presents with the chief complaint of cough and I can't get my air. The patient presented to the clinic for a cough and shortness of breath that had been going on for the past week. He has had no activity tolerance and it's like he cannot get his air. He was seen earlier in the week for the same symptoms. A chest x-ray was completed, which was negative. He has never had anything like this before. He denies a history of asthma as well. He does have a history of smoking. He smoked 1 pack per day for 20 years. He can generally work through illnesses, and currently with this illness, he is unable to tolerate work or even walking across a room. He also has a decreased appetite and has lost about 20 pounds in 1 week. The patient's past medical history includes hypertension, dyslipidemia, and type 2 diabetes mellitus. He has no surgical history. The patient's initials are JC. He's married with 3 children. Him and his family live in a house. He works full-time in the oil field. He has a history of 1 pack a day, smoking for 20 years, and currently denies the use of smoking or smokeless tobacco. He does use alcohol 2 to 4 times monthly. For family history, his mother is alive and well at the age of 66. She does have a history of hypertension and diabetes. His father died at the age of 38 in a motor vehicle accident. He has 2 sisters that are alive and well. He has a daughter that's alive and well, and 2 sons that are also alive and well. JC takes lisinopril, 20 milligram once daily, PO, simvastatin 40 milligram tablet once daily, PO, and Victoza 0.6 milligrams per 0.1 mils, 1.2 milligrams once daily, sub-Q. He also has an allergy to metformin HCl, and for that he had some GI sensitivity, therefore it's not a true allergy, but he is sensitive to the medication. For the review of systems, constitutional complains of fever, weakness, fatigue, and weight changes. For HEENT, he denies headache, history of head trauma, visual disturbances, hearing loss, ringing in ears, pain or discharge, denies nasal drainage, congestions, or epistaxis, denies hoarseness and sore throat. For respiratory, he complains of dyspnea at rest and on exertion, a non-productive cough, but denies wheezing or hemoptysis. Cardiovascular, denies chest pain, exertional chest pressure, discomfort, palpitations, and edema. He does complain of dyspnea at rest and on exertion as previously stated. Gastrointestinal, he denies complaints of nausea, abdominal pain, or changes in bowel patterns. For neurological, he denies decreased level of consciousness, confusion, headache, dizziness, numbness or tingling, and behavioral changes. For his physical examination, his blood pressure was 130/80, his temperature was 98.4 degrees Fahrenheit, respirations were 18, his heart rate was 112, he had no pain, his O2 saturation was 84% on room air, his weight was 327 pounds, his height is 6 foot, and his BMI is 44.3, therefore putting him in the obese category. For constitutional, he's a pleasant 41-year-old who does not appear to be any obvious distress. Patient is in good hygiene and answers questions appropriately. Patient is alert and cooperative. For respiratory, respirations are symmetric and unlabored. No cyanosis noted. Lung sounds are diminished with fine crackles throughout. He does have a dry cough present. Cardiovascular, audible S1 and S2, regular heart tones, no murmurs, gallops, clicks, or rubs, heard on auscultation, no thrills, lifts, or heaves. For gastrointestinal, he's obese, soft, non-tender, active bowel sounds in all 4 quadrants. And for neurological, he's alert and oriented person, place, time, and situation, appropriate mood and behavior, patient follows commands appropriately, his gait is steady and coordinated. Differential diagnosis for this patient include typical bacterial pneumonia, viral pneumonia, tuberculosis, pneumocystis, pneumonia, pulmonary embolism, inhalation/occupational lung injury. The image that's displayed in this slide is an image of a chest x-ray of a patient with Mycoplasma pneumonia. For diagnostic testing, the diagnosis of Mycoplasma pneumonia is generally based on a combination of presenting symptoms. X-ray imaging and serological tests are used since the organism is challenging to isolate and requires special culture media. Clinical manifestations of M. pneumoniae include sore throat, fever, and cough. M. pneumoniae infection manifests on radiology as central lobular nodules with ground glass opacities and thickened bronchial vascular bundles, along with a feathery shadow in the lower left field of one or both lungs. However, the most common diagnostic test used to diagnose M. pneumoniae is serological testing, but this test requires paired serum samples with a 2 to 4 week interval and provides only a retrospective diagnosis. Overall tests that should be included for diagnosis include chest x-ray to assess for abnormalities, white blood cell to assess for infection, hemoglobin, as M. pneumoniae can cause anemia, LFTs to assess for elevation, which occurs in M. pneumoniae, oxygen saturation, which can assist in determining if hospitalization is required, and BUN level, which may be elevated and indicate hospitalization needs. On the patient in the case study, a chest CT was completed to rule out a PE, and blood cultures were obtained as well. For this patient, we actually did not complete the diagnostic testing completely, and the M. pneumoniae was diagnosed in Bismarck. For pathophysiology, M. pneumoniae lacks a rigid cell wall, which allows it to change its size and shape to suit its surrounding conditions. It's also intrinsically resistant to antimicrobials such as beta-lactams that work by targeting the cell wall. Because its lack of cell wall, M. pneumoniae is extremely susceptible to dissation. Thus, bacterial transmission from person to person by airborne droplets only occurs through close contact. M. pneumoniae is exclusively a human pathogen. M. pneumoniae is mainly an extracellular pathogen that has developed a specialized attachment organelle for close connection with host cells. This attachment is crucial to the bacterial survival as well as ability to infect. The close attachment between M. pneumoniae and the host cell prevents the host mucociliary clearance mechanisms from removing the bacterium. The bacterium joins the respiratory epithelial cells and damages the cells at the base of the cilia, which activates the innate immune response and produces local cytotoxic effects. The onset of symptoms is generally gradual and looks like a typical upper respiratory tract infection with a low-grade fever as well as prominent cough. There may also be accompanying wheezing, sore throat, myalgia, and headache. Generally, cases are not clinically severe. However, when complications occur, they may include bronchopneumonia, parapneumic effusions, and necrotizing pneumonitis. Treatment plan. JC was originally seen in the clinic, and upon assessment of vital signs, history, and physical, he was sent to the emergency department. While diagnostic testing was completed in the emergency department, it was decided that he should be transferred to a more capable facility. While in the ED, his oxygen saturation continued to decrease and eventually required 15 liters of oxygen via non-rebreather to maintain oxygen saturation above 88%. He was transferred by AirMed to CHI in Bismarck, where he received treatment in the ICU for 10 days. Therefore, my treatment plan is based upon resources that discuss the topic of Mycoplasma pneumonia. In rare circumstances, M. pneumoniae is severe enough to require ICU admission. The most recommended empiric regimens for patients that require ICU admission with CAP include either a respiratory fluoroquinolone or a macrolide. Modifications of these medications are based on the severity of illness, patient comorbidities, and drug tolerances, local epidemiology, and risk factors for multi-drug resistant organisms. The duration of treatment is more severe in cases generally 7 to 10 days and it is based on the improvement of symptoms. The use of corticosteroids is controversial in the treatment of Mycoplasma pneumonia. However, according to Yang and Lee, the use of corticosteroids may be effective in the reduction of immune-mediated lung injury in MP to prevent the spread of infection. Hand hygiene should be completed. This next slide is an algorithm that was retrieved from UpToDate, which discusses empiric antibiotic selection for adults admitted to the intensive care unit for community-acquired pneumonia, which is also the atypical pneumonia or Mycoplasma pneumonia. Patient education. There was no education that was provided since the patient was transferred to another facility. However, the education that should be provided includes the cause of NP as well as the spread of infection, the symptoms, as well as treatment time and recovery. Other education should include the administration of pneumonia vaccines, smoking cessation, prevention such as hand washing, as well as maintenance such as living a healthy lifestyle. And in this situation, we really encourage the patient on follow-up to start losing a little bit more weight, though his 20-pound weight loss was not healthy in that time frame. Follow-up. The patient followed up 1 week after he was discharged from the ICU, which he was instructed to do so by the providers in Bismarck. At the patient's follow-up, he still had complaints of fatigue and cough. He actually had 3 episodes where he coughed so hard that he had passed out, one of which occurred while hospitalized. During this appointment, he was diagnosed with cough syncope. Cough syncope is a transient loss of consciousness due to a reflex response that encompasses the vasodilation and or bradycardia, leading to systemic hypotension and cerebral hypoperfusion. He was prescribed Tessalon pearls, 100 milligrams PO every 8 hours as needed. The same week, his daughter was having similar symptoms and came in for a clinic appointment where she was directly admitted to the hospital for treatment. The patient then followed up a week and a half later where he was given permission to go back to work and had no more syncopal episodes or symptoms of pneumonia. In conclusion, the case study was a great example of the treatment of atypical pneumonia in a rural community. It gave insight to the critical thinking skills that are necessary in diagnosing different diseases that are more crucial in nature. I was able to see how my preceptor used history, physical examination, and diagnostics to make a diagnosis, which I found is an important part to correctly diagnosing diseases, evidenced by discussion throughout the different evidence-based research resources. It also assisted me in determining the importance of knowing the capabilities of the facility that you're employed when you must send a patient to another facility for a higher level of care. Overall, the clinical experience that I had was beneficial in my future practice as a nurse practitioner. The next slides are my references. And then finally, we have discussion questions, which are: explain the difference between pneumonia and atypical pneumonia. If anything, what would you have done differently for this patient? What other diagnostic tests may be beneficial in diagnosing Mycoplasma pneumonia? What are the indications for outpatient treatment versus inpatient treatment in Mycoplasma pneumonia? And that's my presentation, guys. Thank you.